Here we are targeting ocular inflammation and immunology, the Journal of Ophthalmic Infection and Inflammation, or the Indian Journal of Ophthalmology case report. So now coming on to the first one, the name we have kept, we're thinking of keeping is Halley's Comet in the Eye, choroidal osteoma case series. So why this name has been chosen as Halley's Comet is a very rare sighting which occurs in around 60 to 70 years, and similarly this case is also a rare sighting. So in this current presentation, we have two cases which have a varied presentation. And as the literature suggests, the largest study that has ever been done consists of 61 cases over the duration of 26 years. So coming to the case number one, an 18-year-old female presented with gradual painless diminution of vision in the right eye for the past 15 days. So this, according to these presentations, we can see that we have a young female patient and who has unilateral diminution of vision, which is quite important in this current scenario. Her best corrected visual acuity was 6/9 in the right eye and 6/6 in the left eye. Her anterior segment examination was within normal limits. So on fundus examination, we can see that in the right eye, it revealed a very large juxtapapillary orange yellowish lesion, which approximately was 5 disc diameters by 5 disc diameters, and it extended from the disc to the fovea along the inferotemporal arcade with calcification on the disc. Also, there was presence of some shallow subretinal fluid, which can also be seen on the red free photograph of the same lesion. On doing the OCT for the same patient, we can see a large choroidal hyperreflective space, which was temporal to the disc, and it was extending from the disc to the subfoveal region, again, as mentioned before. And there's definitely a choroidal thickening pattern. And there's presence of mild subretinal fluid pockets, which are just perifoveal also, and also temporal to the disc just above the lesion. So then we did fundus fluorescein angiography and indocyanine green angiography also of the patients, and it showed, these are the early images which showed early hyperfluorescent patchy filling pattern. And in case of ICG, we can see a early hypocynosine presence of the lesion. These are, again, the above images are the early ones, which shows the patchy choroidal filling pattern along the IT arcade and also in the papillomacular bundle area, which in the later stages goes on to being a hyperfluorescent staining. And in case of ICG, we see early hypocynosins in the area of the lesion, and in the later stages, it becomes hypercynosins, and there is diffuse coalescence of the lesion as well. On doing the B-scan ultrasonography, we can see there is a characteristic shadowing or sound attenuation, which is posterior to the hyperreflective choroidal lesion, which gives a characteristic appearance of a pseudo-optic nerve and is a hallmark of this condition, and also gives a sign like a comet's tail. So the investigations were done to rule out if there were any systemic disease process involved or not, and there was nothing. Everything was within normal limits, thus again moving our diagnosis much closer of that of a choroidal osteoma. So this was the first case which showed with first kind of variation, which was with presence of subretinal fluid. So coming on to the case number 2, again here there was 23 years old female patient which presented with a gradual painless diminution of vision in the left eye since 1 month. So again, we can note all these three factors which are there, that the patient is young, she is female, and has unilateral diminution of vision. So the best corrected visual acuity was 6/6 in the right eye, but however, in this patient, the visual acuity was quite decreased, which was 1/60 as compared to the previous case, who had a very good visual acuity, which was 6/9. Her anterior segment examination was again within normal limits in both the eyes. This time on examining the fundus, we can see that the left eye revealed a large juxtapapillary, this time yellowish white, subretinal lesion, which is approximately 2 disc diameters by 3 disc diameters. It is adjacent to the disc with some calcification which is encroaching the fovea. As it can be observed, to a little bit extent in the red-free photograph with presence of some shallow subretinal fluid. So the patient was diagnosed elsewhere as a case of choroidal astrocytic hamartoma based maybe because of the confusion of presence of presentation. So here we can see that some mulberry appearance is present in this on-face image, and characteristic moth-eaten appearance of the retina is present on doing the OCT scanning. But on close observation and more thinking about the proper correlations, we started seeing that since it was diagnosed as astrocytoma, which is a tumor of the nerve fiber layer and involves the inner retinal layers, which is perfectly normal on these scans. There's no sort of tumor involving the nerve fiber layer. Also, we can again see a large choroidal lesion, which is hyporeflective and is surrounded by some hyperreflective dots also. And if we observe closely, we can see that the RPE layer, the Brooks membrane, the RPE Brooks complex, and the inner retinal layers have started showing some sort of degeneration and disruption, which is just overlying the tumor region. And maybe some sort of CNVM has also started developing, which is the second kind of variation with which the patient presents in case of a choroidal osteoma. On doing the OCT angiography of the patient, we can see that the deep vascular plexus and the choriocapillaries layer are of importance, where we can see some dark band, which is again showing some sort of mulberry appearance, which may lead to, making a different diagnosis. But on seeing the choriocapillaries, we can see that there is a very dark band, which signifies that there is decalcification. And the area may have some peripapillary early CNVM formation also, which again signifies that RP atrophic area about which I was talking in the previous slide. So the patient was diagnosed elsewhere as healed choroiditis, query toxoplasma retinochoroiditis, and query choroidal astrocytic hamartoma. But after observation and doing multimodal imaging of the patient, we somehow came to a conclusion that no, this is not a case of hamartoma, but rather it should be a case of osteoma, but she still further needs many more investigations to be done. So on doing the investigations, we saw that everything was from ACE to her blood picture to RBS, the torch panel. It was all negative. Even the dermatologist review informed us that there was no evidence of any vascular nevus, adenoma sebaceum, periungual fibromas, or Chagrine patch, which again ruled out any systemic association of tuberous sclerosis or phakomatosis, which is important in case of a astrocytic hamartoma. So the patient has been sent for neurologist or physician opinion to rule out any other systemic associations if left out. And also we need to undergo FFA, ICG, and B-scan ultrasonography, which would again further confirm our diagnosis of the choroidal osteoma. So coming on to the second project, that is choroidal hemangioma, which I will be presenting as a photo essay in the American Journal of Ophthalmology case reports.
Abhijat, I think yes, what that we can just discuss this, quickly, and then go on to the other case strip, the
sure.
photo assays. So in the OCT angiography, if you go back, in this, and also in the so the two patients basically had a little different presentation. If you see the two patients picture,
right,
the OCT pictures, in one you can clearly see that there's a lot of fluid, and
yes,
both retinal and subretinal, and also juxtapapillary, you can make out something like a CNVM on the OCTA. So I feel that this second case definitely seems to be having a CNVM.
Yes, sir.
As in the first case, if you go back to the the picture in the first case, there it's more like the next one. Yes. So here you can see that there's no clear-cut demonstration of any CNVM, but there is just subtle subretinal fluid.
Right, sir.
Also, if you see the clinical picture of this case, the first case, this is more like an orangish lesion.
Yes, sir.
So what has been described is that earlier on these osteomas, they, present in the form of an orange yellow lesion, and with progressive, changes which occur, in the osteoma, more osseous material is laid down.
Yes, sir. Calcified forms.
Correct. And that is what gives rise to a change in color to the yellowish, the yellowish lesion which we see in the second case.
Yes, sir.
So that is how we can differentiate. So there are basically two cases of choroidal osteomas at different stages, which we have seen. Within a span of a month, we have seen these two cases.
Yes,
And
sir.
this one, because this is a more chronic one, this seems to have been complicated by the development of a choroidal neovascular membrane.
Membrane. Yes,
That
sir.
is, too much intraretinal and subretinal fluid is there. And this case, we have advised anti-VEGF to her, and she's due to come back for that. So that is one thing. Any other investigation which you could have, done in this case, for demonstrating the osteoma, or anything else that we
Yes,
could.
sir. So we are currently awaiting the patient's return. So on her next visit, we are planning to do FFA, ICGA, and B-scan ultrasonography to confirm further the lesion.
Right. So that would be helpful. Also, has any radiological investigation been, kind of described for osteomas?
So MRI can be done. MRI orbit can be done.
Right. And what would you see in that MRI?
So on MRI orbits, again, we can see a calcified lesion is observed, just subretinal area, in the subretinal area. So, which again would give a false sign that there is some sort of, hyper intense lesion present there.
Yeah. So MRI shows a hyper intense lesion, and on T1 it enhances, but on T2 it becomes a
Yes, sir.
low enhancing lesion. So
Yes, sir.
that on MRI. And the second case, I think you tried to show the NFAS images where there was a mulberry appearance, but we could probably see the mulberry appearance, like if you go back to the NFAS image, so the one that you have put here, I think, can show, and it is showing, although I think I saw it much more clearly in the clinic. So I'm not sure why I can't see it so well here, because that mulberry appearance was quite clear. And that is
Yes,
what,
sir.
waylaid us. And in fact, an earlier ophthalmologist also diagnosed it as an astrocytoma.
Right, sir.
And 90% of the patient of practicing ophthalmologists are unable to diagnose an osteoma. So that is written in the literature, that up to 90% wrong diagnosis is made in a case of choroidal osteoma, and it is very difficult to diagnose.
Yes, sir.
It's important to recognize all these signs which we are seeing on multimodal imaging to establish the diagnosis. And hopefully, if we have the FFA and ICG of this patient, then we can, get better idea and get better pictures for documentation of this osteoma. And I think anti-VEGFs are nowadays being used.
Yes,
Otherwise,
sir.
PDT and focal laser and TTT have also been described. The
Right.
only downside of laser therapy is that these laser treatments can induce decalcification.
Mm, mm,
Once
mm.
decalcification is induced, then overlying RP atrophy ensues and vision can deteriorate. So that is a little downside of doing PDT and TTT in these cases of choroidal osteoma.
Yes, sir.
Okay, so please go ahead. Are there any more questions from Dr. Das, Dr. Shweta, or anybody else?
So I think that was the SLO image that we saw in the clinic, where the
Yeah.
mulberry appearance.
So I think this was maybe the IR image, the infrared image, and
Yes, sir.
maybe the SLO image will give us that mulberry appearance much clearer.
Yes, sir.
Yes, sir. Yes, sir.
So any other points that we need to discuss? So if there are none, then we can proceed. You can just complete your presentation, Dr. Abhijat.
Right, sir. So coming on to the second project, that is choroidal hemangioma, which would be a photo essay in American Journal of Ophthalmology case reports. So 39 years old male presented with chief complaints of painless gradual diminution of vision in the right eye since 10 months. His uncorrected visual acuity in the right eye was 6 by 18 and best corrected visual acuity was 6 by 12. The uncorrected visual acuity in left eye was 6 by 6. The anterior segment examination was again within normal limits in both the eyes. So on doing with the fundus examination, the right eye revealed a large subretinal mass which was 5 disc diameters by 5 disc diameters in size. It was adjacent to the disc and along the superior temporal arcade with presence of subretinal fluid in macula which was corresponding to the location of the mass. Also, it was involving the foveal region and that is the reason why his visual acuity was not 6 by 6. So on doing the OCT, we can see a very large choroidal mass which had a gentle slope with RPE irregularities and thinning with presence of large subretinal fluid pocket which involved the fovea and it was present subfoveally. And there was also disruption of the outer nuclear layer and the outer plexiform layer. So these are some hallmark signs of which can be seen in cases of choroidal hemangiomas. On doing the OCT angiography, if we carefully look at the deep layers and the choriocapillary part of the scan, we can see that there is a dense, irregular vascular network in both in the deep and the choriocapillary area, which as compared to the surrounding choroidal network is quite irregular. But it can be observed if we see it very closely. So on seeing the deep area as corresponding to the reddish area, we can see that there's irregular vascular network as compared to the surrounding vessels, which can again be observed in the choriocapillaries area. On doing the B-scan ultrasonography, again we see a hallmark sign which shows a well circumscribed, acoustically solid, dome-shaped lesion. The important part is that the echogenicity of this choroidal mass is quite similar to that of the surrounding normal choroid, which again goes in favor of a choroidal hemangioma. So now coming on to the FFA and ICG images, the left ones are the FFA images, right one shows the indocyanine green images. So in the early stages, we can see that there is some lacy pattern of hyperfluorescence and the ICG clearly shows some hypersinescent areas. So, yeah. So this is the mosaic pattern of the similar image and again it's showing early hyperfluorescence and hypersinescence in the early stages. After 11 minutes of the scan, we can see very large stained area with again some hyperfluorescence and in the case of ICG, we see a large hypersinescent area with some speckled appearance. Now comes the important part, which is the late stage of the disease. So this was the scan taken at 67 minutes and it clearly shows that the lesion has been washed out. The dye has been washed out. So this is known as the washout phenomena. And this is again a characteristic hallmark of the choroidal hemangioma. And the final case which I am going to present is the non-sympathizing sympathetic eye, which is a case of sympathetic ophthalmitis and is a case report. The targeted journals are Indian Journal of Ophthalmology case report or ocular inflammation and infection journal and Journal of Ophthalmic Inflammation and Infection.
Yeah, just a minute. So for the choroidal hemangioma case, so what differentials would you think of in such a case?
So, sir, in such a case, I would also think of just coming on to, yeah. So if this is the case, I would also think of tubercular lesion, maybe tuberculoma. It can, because it might show some signs related to that, like that of a contact sign. And it could also be a case of sarcoid and it could also be a melanoma.
Right. And how do you differentiate these conditions and how did you establish the diagnosis of an hemangioma in this case?
Yeah. So as I was speaking, there are many, we need multimodal imaging definitely to differentiate all of them. And like in B-scan, when we see such a A scan pattern, like the echogenicity of this lesion is just similar to that of a normal choroid. It happens in cases of hemangioma only. However, in case of tuberculoma, the spikes would be varied. In case of metastasis, the spikes would go from high to intermediate and would not be of that of a similar pattern as compared with the normal choroid. And in cases of melanoma, again there would be a spike in two patterns, like that of a M-shaped pattern. Then the male,
that known as the M-shaped pattern, or like early high reflectivity and then progressively decrease.
yeah,
What
yes,
is that called?
yeah, the name is just slipping my mind right now, sir.
So you have an angle kappa in that, right? So there's an
Yes,
angle
sir, yes, sir. Right,
melanoma.
right,
There's
sir.
basically an angle kappa, but here we are not seeing that kind of picture on the B scan. And also on FFI ICG, what are the characteristics that you make the diagnosis of hemangioma?
Yeah, so for hemangioma, we need to see the washout phenomena, which is seen on the indocyanine green angiography basically, where we see early hypersenescence, which keeps on increasing at the mid-peak levels and shows some sort of speckled pattern, after which it's total hyposenescence. So this is known as the washout phenomena, and this is the hallmark of this disease.
On OCTA, what features could you see in the hemangioma case that you were telling, which made you think of
So
hemangioma?
yeah, so in OCTA, what I could find was that there was a very irregular vascular network, considering the deep vascular layer and the choriocapillary layer as compared to the surrounding layer.
So normally we would see, in the choriocapillaries layer, a dense, vascular network, which we can't really appreciate so well here.
Yes, sir. It's very slight,
Yeah,
scarf type of thing.
because our instrument is not a swept source OCTA. So
Right,
in a
sir.
because of the elevation of the lesion, we are not able to get, into the depth of the lesion. And had we, done swept source imaging, we could have, seen that dense vascular pattern in that area.
Yes, sir.
Right? Please go ahead.
So this was a 77 years old female who presented with complaints of painless, gradually progressive diminution of vision in the left eye since 1 month. So I would like to discuss a history, some brief history about this patient. So she underwent cataract surgery in the right eye elsewhere in the month of September 2021. After which, on the post-operative day 2, she was diagnosed at the same place in the right eye as post-op query pan-uveitis in the same eye, in the right eye. However, left eye was not having any sort of symptoms at that time. In the month of October 2021, she was diagnosed as a case of query endophthalmitis. And after that, she was referred to a higher tertiary center. And in the month of February 2022, she was having right eye thicycle eye, and the left eye had panuveitis, again diagnosed elsewhere, and was referred for a second opinion. So when she presented to us, she had a visual acuity of PL negative in the right eye, which was with thicycle eye. The left eye had a vision of 3/60. And on anterior segment examination, we could see multiple diffuse large mutton fat KPs, signifying a granulomatous process going on. The anterior chamber showed 2+ cells and 1+ flare, and there was significant cataract which may or may not be complicated, as we don't know about the previous history of the patient. After this, the patient was started on 1 hourly drops of Predmet topically and homide eye drops, hometropine eye drops, and she was advised many investigations. And the patient later on came back to us with investigations and everything after 5 days. So after 5 days, her photograph showed that right eye, this was clearly a thicycle eye, and left eye, there were previously large mutton fat KPs, which are now not there. Even the reaction at the anterior chamber is reduced. The cells have gone down to trace, and the flare is very minimal or no. Even we can say that there is no flare currently. However, we can see that there are some pigments on the anterior lens capsule, and we can see that there is very dense cataract. So on doing the OCT image, we can see that there are retinal folds and even the choroidal folds are there. So the surface of the choroid, including the RP and the Brooks, is quite undulating. Also, a very interesting finding is that the entire choroidal vasculature does not show normal physiological morphology. It has completely been obliterated. So the blue arrow, it shows that there is a lot of vitritis, and maybe the image does not show vitritis because of significant cataract. But the fundus was even not quite clearly visible, and the inner retinal surface also shows some sort of precipitates present on the surface, and there are many subretinal fluid pockets also. And we could also observe one area of large exudative RD, which was confirmed on diagnosis on B scan, which I'll come on to in the coming slides. So this was the FFA and the ICG scanning done for the patient. The early stages of FFA show some hyperfluorescence, early hyperfluorescence, and the ICG shows some hypocynescent area surrounded by some early hypercynescence. In the later stages, we can see that there is very late staining hyperfluorescence, and there is a very hot disk present in this photo. And in case of ICG, in the later stages, we can see that the hypocynescent area is present, which is surrounded by hypercynescence all over. This was the B scan which was done for the patient, and it shows that the the retinochoroidal thickness has increased uniformly, and there is definitely presence of some retinal detachment, which most probably would be exudative in such a case. So the investigations which we obtained, that were the major investigations, were within normal limits, except that her blood sugar levels were quite raised and the HbA1c level was 8.1. So definitely she is a diabetic. Serum ACE levels were 96. Her BON2 came out to be negative. CRP was also negative. ANA profile was normal. Even the syphilitic profile was ruled out. Kidney was normal. On HRCT thorax, it was suggestive of interstitial lung disease. And on ultrasonography of abdomen, the patient had grade 2 fatty infiltration. So the patient was continued on the same lines of treatment which we advised before, and was sent for a physician opinion for controlling her diabetic levels, the blood sugar levels, and also we needed a clearance so that we could start her systemic steroids, which under certain current circumstances, it's not quite possible to start considering our blood sugar levels. Thank you.
What made what helped you in making the diagnosis of sympathetic ophthalmia in this case, and what are the other differentials that you should keep in mind?
Right, sir. So the very close differential of such a condition would be Vogt-Carnagi-Harada disease, VKH syndrome. So the first and foremost thing which ruled out VKH was the history of surgical intervention. The first criteria which is most important to include the case of VKH is there should be no sort of surgical intervention in the past. So moreover, it has been published in literature also that in cases of VKH, in cases of sympathetic ophthalmitis, we see such a pattern of choroid, which shows that the normal physiology of the choroidal vasculature has been obliterated, and the RPE and the choroid shows such a undulating, lumpy, bumpy sort of pattern. Also on FFA and on doing FFA especially, we should see a starry sky appearance with pinpoint leaks, which I think we cannot see in such an image which we captured. And on OCT, we should also have observed some septa or any bacillary layer detachment, which do not show any sign. Also, the retinochoroidal thickness on doing the B scan was uniformly increased throughout the area, again going against the VKH condition. And the patient did not have any systemic association, like she did not have any poliosis, any vitiligo, and her age was also in the 70s. So again, yeah, she was around 80 years old. So again, going against the diagnosis of VKH.
So what made you do all these the other systemic investigations? What were you aiming to achieve? Like ordered like a serum ACE levels, MAN2, so what was in mind when you ordered these investigations?
Yes, sir. So there was pan uveitis, and it was a bilateral pan uveitis. So generally the sarcoidosis may present, but again there is a granulomatous thing. So I had very mixed thoughts regarding the diagnosis. So I was also thinking of masquerade syndrome, which would involve some sort of metastasis from some tumor. And that's why I ordered HRCT thorax and the ultrasound abdomen. I also ordered for an ultrasound pelvis, which they didn't do, but they also advised that we should go for the same. But by the looks of the results, I do not think that this is going in favor of masquerade syndrome.
Why masquerade is important is because in the extremes of ages, if you're getting uveitis, so whenever uveitis presents in extremes of ages, you have to be careful, and especially in elderly people with uveitis, masquerade syndrome should definitely be ruled out.
Right, sir.
So I think with this, I think what we can do is I would request Dr. Gaurav to maybe have the anterior segment fellows also present, because because I think if Vaibhav presents, then we will not be able to have the anterior segment fellows present. So maybe Vaibhav can present the next time in the next class, if that's okay.
Okay, sir.
So I think the one anterior segment fellow can.
Saurabh, I think thanks for that, and very nicely done, Dr. Vijay.
Thank you, sir.
And yes, I think we can maybe we can take between Dr. Amrita and Dr. This thing. Let's start with either one of Dr. Tulsi. Dr. Amrita, would you like to present first?
Yeah, that's all right. So I'll present.
Sure, great, thank you.
Yeah, is my screen share visible on the slideshow mode?
Yes, Dr. Amrita.
Yeah, we are planning on publishing this case report, which deals with the iris depigmentation post phakic lens implantation. Yes, so we have a 21 years male who has anisometropia, and he was very keen on spectacle independence. When he came to us, so he had a refraction of around -7 in total for the right eye, improving to 6/6 part. And in his left eye, it was almost double, more than rather double of that, improving to 6/12. Coming to the history, so the patient did have a family history of glaucoma. So when we traced back his records, so we found out that patient had been coming to us quite before, I think almost like for 4 years before we had planned the patient for the refractive surgery. So he had a family history of glaucoma in his grandfather. So we were actually looking after the patient as a dissuspect. So on examination, we always found his pressures to be very on the borderline, like they were mostly recorded on NCT as around 21 to 23. And the patient had a deep anterior chamber with a cup disc ratio of 0.7 with sloping rim. Therefore, as a baseline, we did the automated field analysis, and we found out that the right eye showed normal results, but the left eye did show a generalized reduction with the enlargement of the blind spot. So thereby, because being a young patient, so we started the patient on the prostaglandin analog, but that was only done for his left eye. On the other hand, after 6 months, we repeated the visual fields to find out whether there any progression for the same. And we found out that there was an improvement in the visual fields, but because there was a generalized reduction in the sensitivity, which might be explained by anisometropia in the patient. The patient was again closely followed up for around 1.5 years, and we found out that there were no glaucomatous changes progressing. So subsequently, the patient was withdrawn from the anti-glaucoma drugs. We did the retinal examination, and both eyes white without pressure with the myopic change and peripapillary atrophy was found, with the macula being within the normal limits, and there were no treatable lesions in the periphery. The patient was very keen on getting spectacle independence by then, so we did the specular counts, and which came in the normal limits, and the preoperative gonioscopy also showed that the inferior angle was grade 4 open and all the others were grade 3 open, with very few vessels in the inferior angle. We looked at the pentacam for the evaluation for the refractive surgery, and we found out that the corneal thickness was a little on the higher side, and the pentacam shows normal, so that we could plan for this patient. But considering there was a higher correction in the left eye, that is how we changed our plan of action, and we thought of doing a phakic lens for his left eye and a laser vision correction in his right eye. So these are the scans for the left eye again. These are the epithelial maps for the same. That's what, as I mentioned, that we planned for a treatment for the right eye as for the laser vision correction procedure. We did a smile for this patient in the right eye and followed, and also we did a left eye toric phakic lens correction. When the patient came to us in post-operative period, so I think I would like to highlight here only the left eye because that is what we are trying to emphasize upon. So when the patient presented to us on post-operative day 1, his best corrected visual acuity was 6/9 in the left eye, and intraocular pressures were within normal limits. The lens vault was noted around 771 microns. When we called the patient on the next follow-up, so on a post of 1 month follow-up, the lens vault was still maintained around 706 microns. But the patient had an intraocular pressure spike of 38 on NCT and 63 on RBT. So that was quite alarming for us, and we started the patient on the timolol eye drops along with the acetazolamide. When the patient followed us after 45 days of the surgery, so the IOP was under control and the anti-glaucoma medications were withdrawn. So considering that the patient might be a steroid responder, so that is why the pressure spike would have come post steroid in that particular eye. And once the steroids were stopped at 45 days, the IOP was controlled and the anti-glaucoma medications were withdrawn. We followed up the patient at post of 4 months, and the patient complained that in his left eye, he has complaints of polyopia. When we recorded the intraocular pressure, it was within normal limits, but on examination, we did find a diffuse heterochromia for that patient. In lens vault, the noted was 708 microns, and on gonioscopy, the angles were open with moderate to heavily pigmented trabecular meshwork temporally. These are this is on the 4th month that we've done the lens vault. So in this, we can actually see on the OCT that there was a hypopigmentation of the iris that had started by then. So for the discussion, I would like to highlight. So we are thinking of publishing this as a case report because till now there haven't been anything that has
Did we have a dropout? Because even I had a outage and
so we were all disconnected, I believe.
I think everybody was, yes.
Yes,
is
sir.
it a
We were disconnected.
Zoom related thing, or I think was it a 45-minute meeting? We have a purchase plan, so it shouldn't be a 45 meeting. Anyway, let's go ahead.
My screen share has stopped, I think.
Yeah, we can start, from that point again.
Should I start from here or a little before that? Sorry.
We were on that OCT wala screen when we got cut
Achha.
off. Like you were showing us the vault on the OCT, and that heterochromia was evident on the OCT picture as well.
Yes,
So here
I'll
I wanted
just go
to
back
ask you,
that.
Dr. Amrita, that since
Yes,
we
sir,
don't
please.
have any pre-operative pictures of to compare the two irises to iris,
Yes.
so you did mention that we have pre-op OCT, and we have pre-op like the pentacam and the other things, which would have taken at least some kind of clinical picture of
Yes,
both
sir.
eyes.
Yes, sir.
So can we, if we are going to publish this, we would have to show that pre-op both the iris had similar appearance, and there was no difference in
Yes, sir.
the.
And also, sir, for that matter, I feel that we'll have a picture on the OT table also while we were doing the case. So
Yeah,
might
but
as well
there
take
the
a picture
pupil
with
would be
that.
dilated over there, so it would be difficult to comment. And
Yes.
then we don't have it for the other eye. So we would
Yes,
have
sir.
to have, for objective this thing, we would have to have images of both eyes taken on the same device. So maybe you should look at, capture from the eye trace, from the lens star, and they all would have captured, some kind. Even the pentacam would have an iris image. And if they are comparable,
Yes, sir.
because on the OCT, if you can actually see, can you go back to that OCT slide?
Yes, sir. I'll just do that.
So
Yes, sir.
here it's quite evident, and if we can zoom in, you can see that there's a clear-cut, appearance of loss of pigment from the most of the iris except near the pupil. So if we actually have of both eyes shown pre-op and both eyes shown post-op, it would be easy to explain that there's a difference in the pigmentation of the iris, even on this image, even though it's not a color image. But we could definitely find a color image also, maybe from the Lenstar or from the Pentacam or one of the other devices, if we could access those and see if we can, use that for documentation and showing that there was a significant difference in pigmentation. So,
Yes, sir.
also, do we have speculars on this patient? Because that would be another question that might be asked. Like,
The specular, we do have a reading of specular preoperatively. It's
but we
here.
don't have
We
a
do
picture,
have a
right?
reading, but I have to find out whether we have the imaging to it or not.
Right. So I think let's go ahead.
Yes. So coming to the discussion, so I feel this is like the first report which has reported that post the phakic lens is specifically once we have a comparative eye, that the one eye underwent a laser vision correction and the other eye underwent a phakic lens, that there was a depigmentation of the iris that was noted. So the hypothesis to this is that two things. One thing can be because the patient was treated only with the anti-glaucoma prostaglandin analog, which does present with the iris hyperpigmentation. So there might be a hypersensitivity to the iris because of that, which probably could come up with something like this. So for that, I would like to highlight the mechanism of the prostaglandin-induced iris pigmentation for the same. So because the prostaglandin analogs are selective agonists and they act on prostaglandin F2 alpha receptors, and highlighting this, that this article shows that latanoprost has maximum effects. If we compare it with other prostaglandin analogs, latanoprost is in specific a higher probability of iris pigmentation in such cases, which acts on the melanogenesis and the iris melanocytes. So there can be a upregulation of the receptors, which thereby because in this study also they came across patients who came with unilateral difference in the iris colors. So this can be one of our references for it. If we are hypothesizing that it can be due to the hypersensitivity of the iris. And another thing that I would like to highlight is that there's something called bilateral acute depigmentation of the iris. So this they came across with systemic antibiotics like moxifloxacin. But considering that if we say that we are hypothesizing this, then it has to be bilaterally. But again, and we haven't encountered any other patients who come up with moxifloxacin induced depigmentation of the irises. So again,
Dr. Amrita, here I'd like to just interrupt. I would
yes,
like
sir.
to interrupt that here we also use intracameral moxifloxacin at the end of surgery on the eye in which the ICL was done. So that would be another difference between the two eyes.
Yes, sir, that would be. But then again, if we are using, because this study mainly mentions about a systemic dose of the moxifloxacin, not
Okay.
probably the intracameral. And
Okay.
second thing is that we've been using intracameral moxifloxacin for almost all our cases for the endophthalmitis prevention, and we've never
Yes.
encountered something like this.
True.
So
So maybe we should look
probably
for a
to
report for intracameral moxifloxacin and any reports of, iris heterochromia or similar, situation.
yes, sir.
And
Yes, sir.
go ahead, please. Yeah.
Yeah, so I am sorry, but I have just two references. I'm still working on it, but I could not find any depigmentation references further. So that is why I wanted to actually keep the discussion open to everybody from all the departments, that what, according to everybody else, could be a hypothesizing fact that we came up with something so rare in our practice.
So we have a unique case, but we don't have a clear answer to why this happened. And also, Dr. Amrita, it might be nice because we do keep OCT for corneal, this thing pre-operatively and post-operatively at usually 2-3 visits. So it might be a good
Yes, sir.
idea to check if we have more than one visit on the OCT, at which point
Comparatives, yes, sir.
this started. So if we did perform an OCT when the patient presented at 1 month with the raised IOPs, it might be really
Yes, sir.
nice to check. There's a good chance that we did the OCT because we typically do it for
Yes,
for
sir.
the ICL vault, right? So
Yes,
you
sir.
might
Yes,
be able
sir.
to make out if any depigmentation had started by that 1 month period or it started after that. And
Yes,
if
sir.
it started after that, there is another possibility that because of the IOP spikes and the pigmentary glaucoma kind of a thing which patient developed post ICL, there may be loss of pigment at that point for some reason. So
Yes, sir.
again, I'm not very sure, but does the patient have normal IOPs now?
Yes, sir. So presently, patient is not being put on any anti-glaucoma medication. So he was withdrawn at 45 days post-op, and presently he's doing pretty fine without it.
And how long post-op is he now? Like how many months post-op is he?
Uh,
I would think
2021,
about
sir.
6 months almost. Is it?
So a year, less than a
One
year. I
year?
mean, 10 months, around
Okay.
10 months, because he was operated in around April or
Okay.
May. He was operated. So
Okay. So, I would love to have comments from all our other faculty here about what may be the possible causes for this unilateral, hypopigmentation. Of course, the bias is that this is the only eye which was taken up for, for ICL, which is extremely rare. We almost never do two different procedures on the two eyes, but here, because the refractive error was beyond the scope of correction with laser correction, for the second eye, we decided to go ahead with the ICL because it was almost minus 13 with minus 2.5 cylinder, which cannot be corrected with any form of laser correction. Whereas the other eye was well amenable to a laser correction, and that's why we chose to just offer a laser correction for that eye. So, any thoughts from anyone?
So I think it's a good,
Sorry.
thing. My only question is that I am not convinced that it could be due to latinopros, because why would it, leave out the areas of the collarettes and, cause
Right.
pigmentation of the iris, which is, outside the collarettes? I mean, that doesn't make sense. If it had to cause the pigmentation, it would cause of the entire iris, So somehow I think that it has something to do with the mechanical factors and also the IOP rise. It is something to do with, either pigmentary glaucoma or, some kind of mechanical forces which were acting in that area of the iris away from the pupil, which, at the time when there was an IOP spike that caused this, hyperpigmentation. I'm not sure.
Also, latanoprost is known to cause, hyperpigmentation of the iris. So the discoloration is more towards hyperpigmentation, not towards pigment loss. It happened in this patient. That's what I could understand. Is it?
Sir, I would like to
sir,
ask a question.
sorry.
So,
Yes,
Dr.
yes, Dr.
ahead.
Meena.
Amrita, Dr. Amrita, was there any changes in the eyelashes also?
No, ma'am, they weren't.
Okay, because if prostaglandin analog will cause hyperpigmentation of the
Yes,
eyelashes
ma'am.
also, like if you use it for long time. And have you found out anything about like duration, like how many years after the use of latanoprost you get the pigmentation of the like hyperpigmentation of iris? Because now you have stopped the
Yes, ma'am, I'll
anti-glaucoma.
have to.
Now you
Yes,
are not
ma'am.
using the prostaglandin analog. So
You're
maybe
absolutely
Also,
right. In
not
fact,
because of the like latanoprost.
I agree with your thoughts, Dr. Meenal, because we should probably watch. In fact, this is something of a very intriguing case because, this patient had come to us almost 4 years back looking for a refractive solution because of the significant anisometropia. And we couldn't really offer him anything, and he had high astigmatism, not amenable to contact lenses. So we kept deferring his surgery, in fact, because, we were not sure he was looking, he had suspicious cups and borderline IOPs, and we didn't want to jump into any kind of surgical procedure, and we kept delaying it for almost 3-4 years, after which we eventually decided, once it was confirmed that he has no glaucoma, and he was, even his anti-glaucoma drug was withdrawn. I think Dr. Amardeep had seen him about a year and a half back and thought that, the everything looks, the fields were explained by the high refractive error and not by, and also that his vision in the left eye, it was a little bit of a lazy eye, not improving beyond 6-9 parts with best correction, whereas the good eye was 6-6, well corrected. So since we found no changes in field, the generalized depression was not going to change, and the OCT looked fine. So we did eventually, after patient had been almost off medication for a year and was maintaining normal IOPs, was eventually taken up for ICL, with guarded prognosis, and for visual rehabilitation, because patient had literally no other option, because the two eyes had like -6 and -13 was the correction. So I mean, if we wanted to publish this case, but we are still not sure how to explain why this hypo, why this pigment loss happened, except for the mechanical effect. In fact, we haven't yet been able to find any case report of post ICL such a thing happening. Dr. Amrita, could you find anything, any report like this of, if not for unilateral, even with bilateral implantation, have any reports of phakic lens leading to
No,
such
sir.
a?
No, sir. Till now, I could not. I'm looking for in journals, but nothing has been reported. And actually, I was also thinking that, like in a very recent case, that we had encountered that girl in which there was a vault thing that we could actually see even in the undilated post-op day 1, when we saw that the ICL was in place, but yet there was a little bulge on the inferior side. So we have had cases like these in our OPDs, but then yet we have never encountered any typical discoloration or depigmentation in those particular areas also, despite of the fact. So the mechanical factor again becomes questionable in such cases.
And I think the best
Sir,
part is that
What
now
about
patient is
having
not
a
on.
herpetic?
Yes, Dr. Das. Yeah.
Sometimes, sir, even a mild herpetic keratouveitis can also lead to this kind of presentation. That has to
Okay.
be looked for.
Okay. Definitely.
Because IOP spike, discoloration of the iris, we need to see for any pigmented capes, because all these things goes towards, because we get to see a lot of these kind of cases, unilateral herpetic case, IOP spikes, controlled, happens actually many times.
Right. In fact, so you're right. I mean, this can be definitely a possibility. And the only thing is that, since it happened right after the surgery when the patient was on topical steroids, and then, the IOP spike was just then, and then the steroids were withdrawn and the IOP settled down fairly quickly. And after that, we've not had any instance of inflammation or of IOP spikes happening, except for that
Iris
one.
details is also very important, sir. Not only the coloration. If
Yes.
we have to just look for the iris details. If there is a gross means difference between the two eyes, and definitely
Yes.
that has to be.
No, there is a gross difference. Dr. Amrita, can you show us both the pictures of both the eyes on the same
Yes,
screen,
sir.
if possible?
I think it
I
was
think
your
it's on the
first
introductory. Yes.
slide. First slide. Yeah. So my question to you is that
There is a diffuse cross stromal iris atrophy.
Absolutely.
yeah.
It's
So
quite remarkable.
my question, Dr. Amrita, is that at the time when the IOP spike was there, was an anterior segment OCT done? Where was there any kind of contact between the iris and the ICL? Was that demonstrated at that
So
time?
there is always a contact between the ICL and the iris, because the iris sphincter, at least the pupil, comes and rests on the edge of the optic of the ICL. So if you look at, can you show us the ICL vault picture on the OCT?
Yes, sir. This
Okay.
is like
So if you look
the
here,
last picture for
you will always have iris contact with the ICL in every patient.
Okay, but was it changed at the time of the IOP spike? I mean, like, was there any bowing of the iris, anterior bowing of the iris?
We'll have to look for that. I think, Dr. Amrita, tomorrow you should look for OCTs,
Yes, sir,
as
I'll
I
do
thought
that.
also. Also look for the depigmentation and the severity that happened. If we have serial OCT
Yes,
scans,
sir.
we might
Serial
be having
OCTs. Yes, sir.
we will be looking for changes on iris pigmentation visible on that.
Sir, I would like
Yes,
to
sir.
ask one question.
Yeah.
Can we do a dynamic OCT for this patient? Like when the patient is accommodating or if he is looking at near object, we could make out any movement in the iris at that time.
Right. So, in fact, our OCT has an option of doing that. We, in the newer OCTs, you can actually do this video recording. But with Rohit, I've been able to actually do this to see the change in vault by shining a torch from the side and then taking a quick scan. And then, we have to actually record the videos on a phone screen because the computer does not allow us to record the video on the OCT. So, we've managed to do that for a few patients. Here, I think we can try to do that on the next visit of the patient and see if there's a big change in the vault and the configuration of the iris on putting and switching on and off a light source to constrict the pupil and then to let it dilate. So I think that's worth doing. The only thing is that now it's been over 6 months since the patient is off all medication, including glaucoma and anti-inflammatories. We have not seen any cells or flare or any signs of inflammation. No glaucoma at this time. The eye is quiet, but it's just that the patient has, this dyspigmented iris, and so it's kind of unique.
So was there any pigment dispersion in the angle? In the angle.
We did find angle on gonioscopy. We had documented temporally in the angle some pigment deposition because at that time, of course, pigment was being lost from the iris, but now it has stabilized.
It wasn't pre-op, but yes, there was a definite change in the post-op, sir.
There's a report which I could pull out in AJO case reports from 2018 in which there's, advanced pigment dispersion glaucoma secondary to phakic intraocular columnar lens implant. So I posted it on our WhatsApp group. So maybe Dr. Amrita, you could look that up.
Yes, sir.
That should be very useful. Wow.
Yeah, it's in AJO case.
I had a question.
Please go ahead. Yeah.
Sorry, Dr. Amrita, you mentioned that the IOP spike was like in the left eye and then the patient was started on latanoprost. And you attributed that to a possible steroid response. What was happening to the IOP in the other eye? Because he would have been started. No, ma'am. So, ma'am, latanoprost was not started for the patient. It was previously, post-operatively, he was just started on timolol and not on latanoprost. So, but what about the pressure in the other eye? I mean, even if smile was done, other eye was normal, ma'am. Other eye was normal. So then he's possibly not a steroid responder because steroids would have been started even after smile. So if he was a steroid responder, but again, is there probably not an incidence difference between starting a prednisolone and starting a FML, like fluoromethanolone in that eye?
Yes, in fact, I think, in SMILE, we only used topical steroid for a week, and that is fluoromethalone. So maybe even if he did have an IOP spike, it would have settled by the time and may have been missed. Because, I think the SMILE was done first and the ICL was ordered, and patient underwent. I think we would have to look at the instance of the date of surgery for both the eyes. I think there was a gap of almost 15-20 days between the SMILE eye and the ICL eye. Yes, sir. So maybe by the time we probably would have missed that visit in which any IOP spike in that eye may have been seen. But even, and also of course, because with the ICL we use topical steroids in a higher dose and also a more potent steroid, and it goes on for almost a month to month and a half. So the chance of getting the steroid response is more. But then typically, if you have a steroid responder, they may have actually shown a steroid response in the fellow eye as well. But here the confounding factor will be that you may not record a high IOP because the cornea is now much thinner post-SMILE. He underwent a 600 microns ablation. So the pressure recorded may be actually much lower than it actually is. So we would have to do an IOP correction for the SMILE eye as well. But Dr. Ruchika, your point is absolutely correct. We should look at this in more, much more closely to find out, the whole sequence of events and all the documentation that we have done during that time.
Right.
Sir, I was just thinking, I just have one more differential. I was just wondering if it could be an eye syndrome.
Dr. Ruchika?
Unlikely, because pre-operatively his eyes were totally fine, and this is, in all likelihood, it's possibly related to his post-surgery. So I don't think, like pre-operatively, his eyes were totally fine. So I don't think this is ice.
Okay.
I agree. Dr. Amrita, it would be worthwhile to also check out his the patient's visits during the time when he was suspected to have glaucoma to see what was the highest IOP recorded and whether applanation showed pressures, what was really the pressure. And if we have serial fields, it would be worth seeing that how the fields showed changes. And if we have OCT of the RNFL, and we can do one now and compare if how the RNFL has changed, if at all. So all these things would need to be looked at, because it's a very, very rare situation where you may actually do an ICL. I would never actually do an ICL for a patient who was a glaucoma suspect in the first place, but here, because he was pulled off the glaucoma drug as not being a glaucoma patient at all by the glaucoma specialist, so we decided to actually, after waiting for almost an year of glaucoma medication, we went ahead with the surgery because the angles were also open and there were no glaucoma signs in this patient. So we should, I think, go through all these things, and it will be a very good case to report. Dr. Tulsi Priya has shared something just now.
Sir, I found an article where the picture is similar to the picture which Amrita has shown. So next time, I think we should also ask for the medical history, like as this article states that some injections which were used for chronic migraine caused depigmentation of the iris.
Absolutely. And I think I would love to go through what Dr. Saurabh has forwarded, because if there are reported instances of acute depigmentation following phakic lens, that would be closest to our case, actually.
Yes, sir.
So we
Yes,
must
sir.
look for more instances and more reports. I think a good literature search would be in order here. So maybe
Yes, sir.
tomorrow we can spend time looking for more literature, and I'm sure we'll find a few more possible reports of such instances, and then it'll make our study more robust, and we can actually make it more it's a very unique case to publish, actually, but it has to be well researched.
Yes.
So I think that's good. Anything else, Dr. Amrita, that you're planning to publish? I mean, this was the one that you wanted, or should we ask Dr. Tulsi Priya to?
I have others also, but said I couldn't prepare more. I think I'll do it in the next class. I think I have just one to
So
present.
can we have, should we close here, Saurabh, and do this on Tuesday for the remaining, for Dr. Vaibhav and Dr. Tulsi, or should we go ahead today itself? I think, say if we have all had enough for today, we can keep Dr. Vaibhav and Dr. Tulsi for Tuesday. Is that a good idea?
Yes, I agree.
Okay. So I think we can, and what we can do is we can have both of them, and maybe from today's discussion, for all the things that cropped up, we can have an update on Tuesday on at least on this case, and if from Dr. Abhijat's cases, if anything still remains and we need to add more information, we could do that and give 5 minutes to each of them to update us on what more they found, so that we can work towards actually submitting these things.
Sure.
Right?
I agree.
I think with that, if there are no more thoughts or questions or anything, we could close it out. But very useful session today from both speakers. And I think if we do more of these, we will eventually be able to do a better job of actually getting there, and meaningful work to be researched and published. Saurabh, anything? Or anybody else? Dr. Das, Dr. Ruchika, Dr. Shweta.
I think Tuesday we can continue the second part of this.
Sure. Yeah. So I think with that, should we close? Okay. Thank you so much, everyone, for a very productive session, and see you on Tuesday at the same time. Okay. Thanks.
Thank you.
Good night. Good night.